Hello and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. Today on the podcast, I'm joined by our deputy editor, Nick Bostock, to talk about some of the latest news affecting general practice. Coming up, we're talking about the additional uplift to the GP contract for 2024-25 in England, how it's being applied and what it means for GP practices, GP pay and staff salaries. We're also discussing the government's emergency intervention that will see £82 million added to the additional roles reimbursement scheme this year so that primary care networks can employ newly qualified GPs and what we know about how that will work. And we're looking at this year's GMC State of Medical Education and Practice report and what it tells us about how GPs feel about their job and the number of hours they work, as well as a new study in the British Journal of General Practice that says we need to move away from using sessions as a way to define how many hours GPs work. Our good news this week is about very low calorie diets and diabetes remission. That's all to come on this episode of Talking General Practice. So first up, we're going to talk about the uplift to GP funding that the Doctors and Dentists Review Body recommended and the government has accepted and some of the potential issues around this. So Nick, firstly, what did the DDRB actually say about the uplift for GP funding?
So we found out what the DDRB had recommended on the 29th of July. That was the date when the government announced that it had concluded a review of the public finances following the general election, and it was now in a position to set out some of its spending plans, in particular plans around public sector pay. The government accepted the DDRB advice in full. And for GPs, the key bit was a recommendation that the government should award a 6% increase to the salary scales, pay ranges and the pay element of contracts from the 1st of April 2024. So it meant effectively a 6% uplift backdated to the start of the financial year. It's obviously a big step forward from the much lower uplift awarded under the previous government, although to be fair, that previous government did say it wasn't a final offer and that it would also bear in mind DDRB advice to come down the track. But that 1.9% uplift we saw earlier in the year contributed significantly to pushing GPs towards collective action, which is beginning now. The BMA has also made clear that although this is better than the uplift that came in April, it's still nowhere near what the profession wanted in terms of reversing erosion of funding. An uplift at this level doesn't bring general practice back in real terms to the level it had 5 years ago, let alone the level that it had 15 years ago. And another factor that's been criticised by specialist medical accountants was the way the DDRB reached its decision to call for a 6% pay increase. The DDRB benchmarked GP earnings against figures up to 2021-22. That's the financial year 2021-22. And it acknowledged that for that financial year and the one before, GP practice income was inflated by income from delivering COVID vaccinations. And it said that money from the vaccination campaign would largely have fallen out of GP income in 2022-23, but that it couldn't consider financial data from that year until its next year's report because it hasn't been fully compiled, the data for 22-23. The suggestion from accountants is that if the DDRB is saying it knows income has dropped since the period it has data for, that should have been factored into its advice in some way. In any case, this was always going to be an important year for general practice in terms of DDRB advice. From 2019 to the start of this year, general practice was locked into a 5-year contract that had fixed annual uplifts built into it. So the DDRB hasn't been asked to make recommendations on overall uplifts to GP contract funding or on income for the GP partners who hold those contracts while that multi-year deal was running. So it's only been giving advice on the pay rises salaried GPs and other staff who are employed by practices should receive. But this financial year, 2024-25, is the first one after the end of that 5-year deal. So the DDRB was finally able to give advice on the kind of uplifts practices should receive overall. And for partners, as well as the overall advice that staff should get a 6% pay rise, the crucial line from the DDRB was probably this. It said, we expect contract uplifts to be sufficient for the full value of our recommendations to be reflected in earnings for contractor GPs. So that's partners at typical general practices. So GP partners as well as everyone else in general practice, should get a 6% pay rise. That's what the DDRB recommended, and that's what the government has signed up to deliver. But as we'll come on to talk about in a minute, delivering that isn't quite as simple as it might sound.
No, it's not, is it at all? People listening to this may well have also heard our interview last week with BMA England GP Committee Chair Dr. Katie Bramall-Stainer, where she explained that an additional uplift to the 1.9% that brings it to around 6% would not be enough to avert collective action or to prevent further practices from facing some really difficult financial decisions or even practice closures. But Nick, since we published that interview, we found out some more detail about how this is all going to work in the past couple of days, haven't we? I mean, what does this all mean in practice in terms of GP practice income? How is it going to be applied to the contract?
The BMA England GP Committee wrote to GPs this week to inform them that global sum payments, so that's the core funding practices receive through the Carhill formula that underpins the GP contract, would rise by 7.4% in 2024-25. The BMA said that global sum payments per weighted patient registered with a GP practice will rise to £112.50. So that's up by £7.77 compared with the previous financial year. There are a couple of other details in the letter. It said that the out-of-hours deduction remains at 4.75%. And that means that with the increased value of funding per patient, it'll rise from £4.97 per patient to £5.34. And so for the real contract nerds out there, this out-of-hours deduction is something that's been in place since the so-called new GMS contract, effectively the current contract model, took effect in 2004. At that point, practices were given the chance to opt out of 24-hour responsibility for their patients in return for the deduction of this percentage of their funding. Most practices took that option, so are now responsible for their patients only during core hours. Going back to the letter, it also reiterated something that was agreed from the start of the financial year, that QOF funding will not be uplifted in line with the global sum increase. The value of QOF points has still changed for this year, but it's only rising by 3.4% to reflect a rise in the average practice list size compared with the previous financial year. That's not extra funding, it's just an adjustment to make sure that QOF pay keeps up with the growing population and the change in average practice list size. NHS England has said it'll update the statement of financial entitlement to put this into action. And the BMA has said that it expects this new level of funding to be reflected in the September pay round for GP practices. NHS England has also given a fairly clear statement on what it expects the uplift to deliver. It said at the start of the month that the uplift to the global sum is calculated to cover all practice staff, not just GP partners and salaried GPs. This includes practice nurses, reception, management, and other practice staff. We firmly expect GP partners to honour the intent of this uplift and award the full 6% pay rises to all their staff. The BMA has also said that it encourages practices to pass on the full uplift, but it's also been clear that practices have the right to decide what pay rises to award their staff, perhaps with the exception of salaried GPs in some cases employed on the BMA model contract, which sometimes has a DDRB clause built into it. But what all this means will really vary from practice to practice in terms of affordability and just how far this uplift will stretch. So the question is, how well does this uplift deliver on the promise to implement what the DDRB recommended?
Yeah, well, that's the big question, isn't it? What are some of the potential problems we could see with all this in the coming weeks? Before this latest announcement about the global sum uplift, the BMA was warning that many practices might not get enough to pass on a 6% rise to all their staff, and probably unlikely to get enough to give GP partners much at all. We know that this was certainly a problem with last year's uplift for staff salaries that came later in the year. Is that the case now? You've spoken to some accountants and others about this. What's their assessment of what this 7.4% uplift will mean for staff pay?
I think the first point to make is that this is a much better settlement than last year's. You mentioned just now that last year's uplift didn't provide practices with enough money to implement the uplift the government promised. Rishi Sunak said last summer that all employed staff in general practice, including salaried GPs, would get a 6% pay increase for the 2023-24 financial year. But then the actual uplift provided to practices through the GP contract didn't cover the cost of that rise. So partners will have to choose between not awarding it, which would mean unhappy staff, potentially staff choosing to leave, or awarding that pay rise and losing out financially themselves. We know of practices that did award that uplift and took the hit, but the BMA and the Royal College of Nursing said jointly last year that some practices just didn't have the money, so they weren't able to offer that pay rise. So this year, specialist medical accountants say that the uplift will give practices enough money to deliver the 6% pay rise for staff that the government's promised, and that for most practices, it looks like there will be something left over once that's done. And that means most GP partners should also see a pay increase this year. But as I mentioned earlier, the DDRB advice accepted by the government said partners should get the 6% uplift along with everyone else in general practice. So will this uplift deliver that? What we're hearing from accountants is that there's no way it'll meet that aim. So partners' income could rise slower than everyone else's again. And if that's the case, what we're actually talking about is half of GPs in England, because roughly half of GPs are in partnership roles, and they actually make up about 58% of the full-time equivalent GP workforce. Half of GPs in England won't get the pay rise the DDRB recommended.
So why is that? Can you explain why accountants think there won't be enough money for partners to see that uplift that they're expected to give to everyone else?
The main reason is that the funding increase isn't being applied across all income streams for practices. Most of practices' basic NHS income comes from the contract funding formula, which gives them a payment per registered patient, weighted largely according to the age and sex of those patients. The total amount each practice receives from this formula is called their global sum, and that makes up about 70% of practice income in general, according to accountants. The rest, so roughly 30%, comes from hitting targets in the Quality and Outcomes Framework, or QOF, and from things like enhanced services. Those are services outside what practices are expected to do for the money they get through the funding formula. Extra services, basically, that can be commissioned either nationally or locally. It'd be things like membership of a PCN, that kind of stuff, but it's also phlebotomy services and minor surgery, those sorts of things. As I mentioned earlier, this year's contract uplift is being delivered through an increase in practices' global sum. So the 7.4% uplift we mentioned earlier applies only to about 70% of funding that practices are receiving. Funding for everything else, as far as we know, so nearly a third of practice income, is standing still. So all of those income streams contribute to practice profits and help pay for staff that practices employ. So a zero uplift on 30% of income is clearly a big issue. It's worth mentioning here too that there's a lot of variation between practices. The idea that global sum makes up 70% of total practice income is a sort of estimated average. So for some practices, the uplift is being applied to potentially a fair bit less than 70% of their income. Another factor that will affect how well practices do out of the uplift is the proportion of their total income that goes on staff costs. The DDRB says that staff costs account for between 58% and 72% of costs for partners. So there's quite significant variation. And the fact that the uplift is being applied uniformly to global sum for everyone means it'll go further for some practices than others. And we know too that some practices spend more than 100% of the income they receive from their global sum on staff costs. So they're reliant on other income streams too to cover staff pay. And if those income streams don't go up while staff pay does, they're likely to lose out financially. And one other factor that will affect how well this uplift works for GP practices is the minimum wage. The minimum wage went up by around 10% in April this year. So any staff employed in practices on or around the minimum wage will already have received a pay rise of well over the 6% recommended by the DDRB. And no part of practice funding has increased by enough to match that, all of which eats into what's left over for partners' take-home pay.
I mentioned earlier that Katie Bramble-Stainer said last week that 6% was not enough to avert collective action and prevent more practices from facing potential closure. But the information we've seen this week suggests, it's a little bit more than perhaps everybody was expecting. But what do you think this uplift, the final details of this uplift, what do you think it means for collective action?
We got hold of quite an interesting sort of rallying cry from the BMA GP leadership that went out to GPs this week. This was a message sent out on a messaging app, which basically said the uplift wasn't enough and that now was not the time to waver, that practices should press ahead with collective action as planned. So I think that's pretty clear about the BMA's intent. And the BMA has said that practices needed a 10.7% uplift just to bring them back in real terms to the level of funding they had in 2018, before the 5-year contract we talked about. So this uplift is well short of that. And as we've said before, funding has been eroded by about 50% since 2015 in real terms. So practices are much worse funded now than they were a decade or a decade and a half ago. But they've broadly tried to keep services going and often taken on more work despite funding going in the wrong direction. And now they're drowning. So what collective action is about is in part taking control of workload through things like adopting safe working advice, limiting appointments per GP to a safe level. But it's also about saying that the idea of goodwill, the idea that there are services that practices just provide for free, and we've estimated in the past that the value of services practices are delivering but are not paid for is at least tens of millions of pounds a year. The financial headroom, basically, that practices might have had in the past to just carry on doing that work is gone, particularly when big chunks of their income streams are still not going up at all. So collective action is also a chance for practices to take a stand over that unfunded work they deliver, and to say that, particularly in the context of funding being eroded over time, they're no longer prepared to offer those services as much as often they want to keep them going for their patients who may rely on them.
That's a really important point, isn't it? I mean, some of this, the BMA definitely is characterising collective action as a way for practices to take back control of their workload, as much as it is about pushing for a better deal for practices. It's also about giving practices the tools and advice they need to take control of what's coming into the practice and how they actually deliver the work they need to do. So it is more than just pushing for a better deal. So along with the uplift to the global sum and the GP contract, we've also seen the government announce a further £82 million for the additional roles reimbursement scheme, the ARRS, which it says will allow for the recruitment of 1,000 extra GPs this year. And adding GPs to the ARRS, GPs and practice nurses to the ARRS, is something that many people have been pushing for some time. Again, I spoke to Katie Bramstone about this on the podcast, where she set out the BMA's view on all of this. But since then, there's also been a bit more detail about how that's going to work, although there are still quite a lot of unanswered questions about that funding. So when it was first announced, the government described this as an emergency intervention to tackle the absurd GP unemployment crisis, which we've talked about many, many times on the podcast. There are a lot of GP registrars qualifying this summer, and there is a huge amount of concern that many of these doctors will not have any jobs to go to, because underfunding, as we've talked about at length already today, means that practices simply cannot afford to employ them. So the government plan is for this extra £82 million to be added to the ARRS this year to pay for GPs. That money is coming from the Department for Health and Social Care's existing budget. Earlier this month, NHS England provided a little bit more detail on how that's going to work, as I said. So this money will not be available for primary care networks until October. So effectively, it's a 6-month fund that runs from October to April next year. The network contract directed enhanced service, so this is the contract that PCNs operate under, that's going to be updated with full rules about how the money can be used. But what we do know from NHS England already is that the money will be separately ring-fenced, so it can only be used to recruit GPs. And a letter to practices and networks from NHS England suggested that PCNs will not be able to use any of the current ARRS money that they already receive to hire GPs. So that money is still separate for the current roles under the ARRS. The letter also said that while this is an emergency fund for this financial year, any additional costs to PCNs will be considered in future budget setting, although it's not really clear what that means and whether this means that the money will be recurrent in subsequent years or how that could even work. So we clearly need more detail on that. NHS England also says the funding is for recently qualified GPs. So when the updated DES is published, we may see that quantified in some ways. So perhaps the money will only be able to be used for GPs who've qualified in the past X number of years, maybe. What was interesting about the NHS England letter is it said that the problem of GP unemployment was in part a result of more doctors entering GP training following a big expansion of GP training places 3 years ago. Yes, this has obviously got some role to play in this, but we've seen this growing crisis in GP unemployment over the past 6 months at least, and it seems to have got progressively worse over that period. The RCGP warned in June that most job-seeking GPs were struggling to find work. A BMA poll also in June found that more than 4 in 5 locum GPs either can't find work or can't find enough work, with many planning a career change as a result. So this jobs crisis was always going to be a huge problem this summer, even if only the usual number of doctors had qualified as GPs, not this expanded cohort. So, as I say, there's still a lot of questions about what this all means. And also the funding to recruit 1,000 GPs isn't even enough for one full-time GP per PCN, is it?
As you said, we've yet to see the full detail on how this is going to work, but that's right. On the face of it, if we're talking about around 1,000 GP jobs, there are about 1,250 PCNs in England. So it's a fair way short of one extra GP per PCN. If it is a maximum of one ARRS GP per PCN, people have also asked whether that's fair. Perhaps the distribution should be geared more towards underdoctored areas, for example, to try to create jobs where there are the highest numbers of patients per qualified GP currently. So might it be better to have multiple ARRS GPs in some areas and none in others? There are some questions also about the fact that at this stage it's just a 6-month deal, as you mentioned. Is that sort of job offer going to be more tempting for a newly qualified GP than a job in Canada or Australia, for example, that might be better paid and more secure for a longer period of time? And in terms of the money, initially there were some doubts about whether the £82 million was enough to recruit 1,000 GPs. But I think that once it became clear this was for 6 months, the sense is that perhaps there is enough money to make it work. But there are still a lot of questions. If these jobs involve working across a PCN, is this a good way for newly qualified GPs to start their careers without the mentoring and support that being attached to a specific practice might offer? Or is there a way to make sure that mentoring is offered? And for practice, we've seen some warnings from lawyers too about needing to be careful about the types of contracts these ARRS GPs are signed up on. So hopefully a guarantee of more permanent funding will come down the line. But if it doesn't and these jobs end after 6 months, practices need to be sure that as a PCN, they aren't liable for redundancy costs, for example. I think another big question about the ARRS GP's plan is that, as you mentioned, the wording seems to suggest that it's geared towards newly qualified GPs at the start of their careers. And we know that those aren't the only GPs who are affected by the unemployment crisis. So why is it exactly that these jobs are not going to be opened up to experienced GPs who are out there in the workforce looking for work and potentially struggling to find it?
As you say, I mean, lots of questions. So we have to wait for this updated contract to see if any of those questions are actually answered in a way that makes sense for everyone. On saying all of that, all of those problems, this is obviously a step in the right direction, even if it is a very small step. And Katie Bramwell-Stainer last week was really keen to point out on the podcast about the need to be positive about this and potentially using this as a stepping stone to negotiate maybe an expanded GP retainer scheme and funded fellowships for newly qualified GPs in next year's contract. So, that's certainly something we should be looking out for in future. One other thing worth mentioning about all of this is that while neither the ARRS changes nor the contract uplift go as far as the BMA or most GPs would want them to, Health and Social Care Secretary Wes Streeting has written to all GP practices in the wake of the initial announcement about the uplift and the announcement about the ARRS change to say that those two measures were simply the first steps towards a more sustainable future for general practice. So clearly, he didn't provide any more details of what those further steps would be and what we might see in the future, though. But clearly, that letter was sent at the start of this month. So I think it was very much in response to the results of the BMA ballot on collective action. I think it was an attempt maybe to calm some of the anger from the profession and highlight that GPs, now have a new government that they're dealing with. He said he knows the GP contract needs reform and he wants to work in partnership with the profession to deliver improvements to general practice and reset the relationship between GPs and the government. Because obviously, after 3 years of imposed contracts, I think relations between the previous government and general practice was pretty much at an all-time low. But as I say, there are really no promises of anything concrete from the current government yet. that's likely to come in the near future. So Nick, just before we finish on all of this, one of the collective actions the BMA is asking practices to consider is not signing up to any of NHS England's pilots looking at how new models of primary care can work. I mean, we talked about these pilots a month or so ago on the podcast. So these are pilots where NHS England plans to work with a small number of PCNs to look at operational changes that would optimise the GP operating model. That's a quote there. We revealed in June that the PCN test sites could be offered seven-figure sums to take part in these pilots. The BMA put out a bit more information on why they're asking practices to avoid getting involved with these pilots this week. What did they have to say?
The BMA's opposed these pilots from the start. I mean, basically, they want NHS England to focus on supporting the existing model of general practice to emerge from a period of crisis rather than coming up with new models of care and putting additional money into that sort of approach. As you said, the BMA's asked practices not to sign up for these pilots anyway as part of collective action. And they were asking practices not to take part anyway before the collective action kicked off. But for practices that are considering it, this latest advice is about some concerns the BMA has about the types of contracts they're being asked to sign and the implications that those might have. So the BMA says it's concerned that the agreements could trap practices in the PCN DES for a number of years, basically removing the right practices usually have to choose each year whether or not to opt in to the PCN DES. That's the part of the contract that governs membership of a primary care network. They're worried that the contract could also force practices into excessive demands around sharing information about their income and expenses. So practices could be trapped because the pilot deal commits them to remain part of their PCN for the duration of a multi-year agreement. So if something changes, if other practices in the PCN close down or merge, for example, a practice trapped in that deal could find itself in a difficult situation financially and unable to pull out. On the point about sharing information, the BMA says the deal practices are being asked to sign up to could create what it calls an open book situation around the income and expenses of practices within a pilot area. It says basically there's an excessive demand for data to be shared that could mean practices have to share really detailed income data with both the ICB that commissions the service and other practices in a way that not everyone might be comfortable with. And they also raise some concerns about the level of workload involved in some of the data collection plans in these pilots. So for any practice considering going ahead anyway, there's a fair bit to think about here.
Moving on, one of the other things that GP Online has reported on in the past couple of weeks is the GMC's annual State of Medical Education and Practice report. Nick, you wrote about that. Before we look at this year's finding, what exactly is this report?
So this report's something the GMC publishes annually, looking at trends in the medical workforce. It looks at how satisfied doctors are with their jobs, whether they're struggling with the level of workload they have, whether they're at risk of burnout, and it produces facts and figures to show how different groups of doctors are faring and how they compare.
And what did the report have to say this year about general practice? It doesn't really make for very happy reading. I mean, to be fair, the last few years of this report have not made for very happy reading about general practice. But what did this one say?
This year's report highlighted in particular the way that low satisfaction and workload pressure have pushed GPs to reduce their contracted working hours. And it found that 29% of GPs cut their contracted working hours in 2023. And it pointed out that this is way higher than the average across other groups of doctors. So across all doctors, just 19% reduced their contracted hours. The report said GPs are the least likely to be satisfied and the most likely to be struggling with their workload across all groups of doctors in the NHS workforce. And basically, they're cutting the hours they're contracted to do to try to avoid burnout and to deal with some of these issues around feeling overworked and a lack of job satisfaction. So it really makes the link between unsustainable pressure on general practice and the way that the workforce has stalled despite large numbers of new GPs being trained in recent years. The GMC said there was a small improvement in the proportion of GPs at high risk of burnout in 2023. It said 21% were at high risk compared with 31% the year before. But it said that there was real concern that GPs have what it called consistently and persistently worse experiences than other groups of doctors.
One of the things that's quite interesting about this is the report came out in the same week as some new research that was published in the British Journal of General Practice, which found that the way we measure how much time a GP works, so this is in sessions, that research found it's not really fit for purpose anymore, is it? What exactly did that research find?
Yeah, so this was a bit of research that came out just a few days before the GMC report. And the timing's really interesting. I mean, this was research from the University of Manchester, and it found the proportion of GPs working full-time is massively underrepresented in official statistics. The research found that 55% of GPs in England work at least 37 and a half hours a week, which is the definition NHS England uses for full-time work. But this figure of 55% is well over double the proportion of GPs who are recorded as working full-time in official statistics. So the official workforce stats suggest that only 21% of GPs are working full-time. So why the difference? Basically, the figures NHS Digital use rely heavily on the number of sessions GPs are contracted to work rather than the actual number of hours they work. BMA definition of a session is 4 hours and 10 minutes. And by that definition, a 37 and a half hour working week would be achieved by 9 sessions of work. But GPs have been saying for a long time that much less than 9 sessions is full time. And this research found that the average length of a session reported by GPs was more than 50% longer than that 4 hour, 10 minute definition. So the researchers worked out that a full-time working week of 37 and a half hours was completed by GPs on average in just 6 sessions, so not 9. And so far, far more GPs are in reality meeting the definition of full-time work than the official statistics would have you believe.
And what did the authors have to say about this and what this means for general practice going forward?
Yes, I mean, their view is that the use of sessions as a measure of GPs' work commitment should be scrapped. It's not fit for purpose, and that actual working hours should be measured instead. And that could be a step towards fairer pay for GPs, but it could also help to push back against some of the negative media narrative around part-time working in general practice.
Before we go, we've just got time for our good news story, and this week it's about the latest results from the Diabetes Remission clinical trial, or the DIRECT trial. So this trial is looking at whether a very low calorie diet based on soup and shakes can help put type 2 diabetes into remission. The latest results published earlier this month found that 1 in 3 people who completed the weight loss programme put their type 2 diabetes into remission in a year. This is a joint initiative between NHS England and Diabetes UK called the NHS Type 2 Diabetes Path to Remission programme, bit of a mouthful there, which provides a low-calorie total diet replacement treatment to people living with type 2 diabetes and obesity or overweight. Participants follow the low-calorie diet replacement using soups and shakes that make up 800 to 900 calories a day for 12 weeks. They also receive support and monitoring for 12 months to help reintroduce food after that initial 12-week period. The latest findings show that among people who completed the programme, 32% have put their diabetes into remission, with an average weight loss of nearly 16 kilograms, which obviously brings huge long-term health benefits to these patients. Diabetes UK said the findings add to real-world evidence that the programme could help thousands of people living with type 2 diabetes on their weight loss and remission journey. Well, that's it for this week. Thanks so much to Nick, and thank you for listening. I'll be back next week, so please do join me then. In the meantime, don't forget you can keep up to date with all the latest news affecting general practice and access many other resources on our website at GPonline.com.